All right, and it looks like we're live, so pretty excited to have everybody here. We have a lot of people, people are going to be online, and hopefully we get some more people here in the building. I think everybody's pretty excited about watching this online, but I've got some really great physicians here to help us, and then also we have a physical therapist here to talk today about throwing injuries in youth baseball. So really excited for Dr. Butler and Dr. Edwards and Dr. Davis. Davis, correct? Yep. And Jared Mortensen, he's a doctor of physical therapy. So happy to have these gentlemen here to talk to us about throwing injuries. And what my hope is today, when you walk away from this recording, this lecture, is that you, if there's only one thing you know, it's when you go to a baseball game and you're a player and you show up to the game. Don't just show up, drop your bag down, get your glove, get your ball, and start throwing, okay? We do not throw to warm up in baseball, okay? We have to warm up correctly to throw so we can prevent injuries. And so that's going to be a lot of what we're talking about today. We're going to be talking about pitch counts. We're going to be talking about some surgical injuries, some non-surgical injuries, and how to prevent these. And then we're also going to do a little demonstration on how to prevent some of these injuries using resistance band therapy, and I'm going to show you how to make those as well. So first up, we're going to start with Dr. Edwards, and I'll let him introduce himself, but essentially he's a sports medicine orthopedic surgeon, specializes in shoulders and sports medicine, right? And he's got some cool credentials, so we're happy to have him. Thank you so much, Dr. Edwards.
Hey, thanks for having me. If anyone can't hear me, I guess just let us know in the comments. Awesome. Well, my name's Gary Edwards. I'm an orthopedic surgeon here in Utah County. Super excited to be given this presentation on operative throwing injuries from the orthopedic surgery world. Baseball is something near and dear to my heart. Fun fact about this picture here on the left, that is me. That is not taken from this century. That picture was taken in 1999 as I was a junior in high school pitching. One of the reasons why throwing injuries and preventing them specifically for tonight's talk is near and dear to my heart. One of the teams that we played this summer had a young player on the team that was between mine and my brother's age. We knew him really well growing up. He was a stud athlete. Basically, every traveling team in the state of Utah recruited him to pitch for them. He pitched for several, probably pitched for too many of them, and completely threw out his arm when he was 16. And about 3 months after this picture was taken, he had surgery on his shoulder, on his throwing shoulder. He got hooked on narcotics, and I just saw his mom as a patient about 3 months ago and found out that he had overdosed and died from narcotic use. The literature says that 5% of adolescents that have surgery either overuse, misuse, abuse, or get addicted to narcotics after surgery, and that's all comers for surgery. So it's certainly not something that we want to take lightly. I have an ulterior motive for this talk, and that's to try to convince everybody to do everything they can to prevent themselves from having to have an orthopedic surgery for a throwing athlete. So, Houston, there's a problem. These are my signs that you have a problem, right? Shoulder or elbow pain when throwing, like when actively throwing, that's a problem. Pain or soreness that persists after a day or two. It's normal to go to the gym, lift weights, feel a little bit sore, but then the next day feel better, and the next day feel better after that. If the pain and soreness persists, that's a problem. Swelling or tenderness in your arm. Worsening performance. This one's a little bit more subtle. So if your performance is dropping, step one, look for a Houston Astro trying to tip your signs and banging on garbage cans, kind of giving away the signs. 2, you could potentially be fatigued, tired. Take an inventory of how much you've pitched, how sore you are, how tired you are, and it might be time to take a little bit of a rest to come back rejuvenated and better overall. Loss of velocity and loss of pitch control are 2 kind of major signs that something's wrong. This is one of the major injuries that we see that's oftentimes can be surgical, is a slap tear. So what does a slap tear mean? It's the superior labrum. The labrum is pictured right here. I don't know if you can see my cursor. Hopefully you can online. But the labrum is this structure, this cartilaginous structure that goes around the shoulder socket. It gives stability to the socket. The biceps tendon comes here and attaches to the top of that labrum. When you tear this labrum, it's called a slap tear. It's because it's the superior labrum and it tears from anterior to posterior. This is the mechanism by which slap tears happen, right? Thrown overhead, throwing a lot. You get really tight here as you throw, you stretch out, injure, damage this posterior capsule, and as a result, it tightens up, right? You lose a little bit of your internal rotation. The arm wants to externally rotate more, and the humeral head slides up, creating more force across that labrum and can lead to a tear. This is Mark Pryor. My wife grew up in Chicago. She was a huge Cubs fan and was obsessed with Mark Pryor back in the day. He was Rookie of the Year in 2003, the year following his Rookie of the Year season. He had a 2.43 ERA, just had nasty stuff, right? He developed a slap tear in 2006, and he was never the same. 7.21 ERA in 2006. He never got back to Major League Baseball. You know, he did a couple minor league stints, but just was never the same. Orthopedic surgeons, when they do surgery, they track something called the return to play. You have to take the return to play stats with a huge grain of salt, right? So sometimes if they show up after surgery in uniform on the field and sit on the bench, that's counted, yep, they return to play, right? Sometimes if they make a minor league start for a Major League Baseball player, they make a minor league start in a uniform, yep, that's return to play. So the real number to look at is return to prior performance, meaning their walks and hits per innings pitched, their ERA, their velocity, the spin rate on their fastball is about 7%. So if you end up having to have a slap repair on your throwing arm, you have about a 7% chance of getting back to where you were pre-injury. So this is like where an ounce of prevention is worth a pound of cure, right? Preventing that slap tear by stretching out, and I won't take thunder from the next guys that are going to talk about how to prevent some of this stuff. 7%. This is a little surgical video of what a slap tear looks like. On the bottom of the screen, this is the glenoid or the socket. At the top of the screen, this is the labrum. This is where the biceps comes in and attaches to the labrum and it's torn, right? The probe is going here across the top of the labrum, and you see that little peel back sign here on the top. Like when the humeral head rides up, because your posterior capsule is stiff, it starts to peel back that labrum and biceps anchor, and this is what it looks like fixed, right? I'll just pause it there. We put two little special anchors, they're kind of like drywall anchors, and we pass this heavy suture around. It's a good surgery to help with some of the pain relief, but if you want to get back, if you're in high school and you want to play college sports and you have this injury, it's really, really, really tough to get back. It's much easier to prevent the injury than it is to recover surgically afterwards. Similar thing with a rotator cuff. Rotator cuff tears often happen in the follow-through or the deceleration phase of the throwing cycle. Let me just show you this. Here, I'll get back for those wanting to kind of screen capture this, this slide. This is kind of a left-hander here on the throwing motion. The rotator cuffs happen at this phase here. It's called the deceleration phase. You do all of this work to get your body winded up, cocked up, exploded forward with your legs, rotating with the trunk, pulling your arm down, and throwing this, whipping this arm and elbow through as fast as you can. Well, as soon as you let go of the ball, the rotator cuff's job is to decelerate your arm. And so the rotator cuff fights to maintain control. It's called an eccentric contraction. What that means is an eccentric contraction is like when you take like a dumbbell for bicep curls and you slowly lower the dumbbell, that's an eccentric contraction, meaning your muscle is lengthening as you're firing the muscle because you're controlling the weight. Here, your arm is continuing to move as your rotator cuff attempts to slowly control your arm through follow-through. And too much wear, too much use, not enough stretching, tight posterior capsule, impingement, too much tensile strength can ultimately lead to a rotator cuff tear. If you haven't seen video highlights of Johan Santana, you have homework. Go home, pull up YouTube, and watch this guy pitch. He had just a filthy changeup, was a ridiculous pitcher, two-time Cy Young Award winner, was probably towards the twilight of his career, but in 2010 was operated on for a rotator cuff and was never the same. Again, these numbers support it. If your rotator cuff is so small, right, and again, there's non-operative treatments for these things that we try to do beforehand. But if you get to the point where you failed non-operative treatment and you just need a debridement, so just go a cleanup surgery of your rotator cuff, about 50% return to play, right? That's 50% of the time the player shows up in uniform at some point on the field. That has nothing to do with how well he performs, right? If you have to have that rotator cuff repaired because it's a significant enough tear because you've either waited too long to tell somebody that it's hurt or you've done significant enough damage, that's about 33%. And if we're looking at return to prior level, it's about 14% of people get back to the level that they were before their rotator cuff was injured. So again, an ounce of prevention is worth a pound of cure. Now, a lot of people have heard of ulnar collateral ligament tears and the surgery associated with it. It's the Tommy John surgery to reconstruct this ligament. And there's a lot of false information out there about, well, you have Tommy John surgery and you come back throw faster than ever, right? Well, this is what happens. This is Billy Wagner. Billy Wagner was like one of the OG, like 102 mile an hour fastball guys. And you can just see the amount of torque he's putting on this elbow, right? It's all of this energy that he's built up in his power and his legs and his core driving forward, and it's all going to be released through his elbow into the ball to go 102 miles an hour. Well, this ligament right here, this ligamentous complex, is the only thing kind of keeping his elbow from dislocating. This ligament and this little piece of bone here are the two things that are keeping that from dislocating. And so it's holding on for dear life. Overuse over time wears down this ligament, and there's not enough time for the body to repair it, right? The return to sport is a little bit better for this, but be cautious, right? Oftentimes you see a decrease in velocity as a result of the ligament tear. So you might be a 75 mile an hour fastball thrower, and then you develop to be a 71 or a 60 or a 69 or a 70 mile an hour fastball thrower. Well, yeah, if you have surgery, you might get to 72 miles an hour, but the spin rates are never the same, right? You may even be able to get close to the same mile per hour rate after this surgery, but the spin rates are never the same. You're never the same after this surgery. This is a little video showing the surgery. This is the inside part of the elbow, kind of right where the funny bone is, or the ulnar nerve. In fact, sometimes if you injure this, you can get numbness and tingling in your small and ring finger as a result. This is a drill. We drill. There's kind of two different ways to do it. This is the less gory, bloody way to do it, right? This is just putting in an internal brace and repairing the ligament. I showed my wife the picture of the full reconstruction with transposition, and she thought it was too much for people to do with internal brace version. But we're drilling holes into the humerus. We're drilling a hole into the ulna. We're trying to recreate the exact footprint of where this ligament lives and reconstruct it or repair it. The tension, getting the tension right on this surgery, let me just go back a little bit, is kind of everything. You can see there's a little probe here underneath this repair stitch to make sure that you don't over tighten it. We're talking about millimeters here make a difference. And that's essentially the surgery. There's a long rehab and recovery. There's an average of over a year out of sport for the Major League Baseball guys. Some guys essentially have 2 years off before they're really pitching like they were before. Again, these are just a few of the common injuries. I've just brushed on, 3 of the most common orthopedic surgery cases that we see. But the moral of the story is that anything you can do to do any of the things that the guys are about to talk to you about in terms of preventing the injury is really the way to go. All right, thanks so much.
All right. So super happy to have Dr. Edwards here. And those that are online, we've got a decent crowd online, so we're excited about that. So now we've got Dr. Anthony Butler, and he's the program director for the Utah Valley Sports Medicine Program, and he is the associate medical director for sports medicine at Intermountain Healthcare. So really happy to have him. He's an expert in this field and prevention, and a really good colleague of mine. I have totally changed the way I practice since he showed up, because he's a super, super big help for me in taking care of my patients and helping prevent me from ordering MRIs and keeping costs down. So we like him a lot. So thanks for coming, Dr. Butler.
Thank you, Eric. I really appreciate that. So I will. No. I'm also going to introduce my sports medicine fellow to you, Dr. Shane Davis. So Dr. Davis is here doing a one-year fellowship with us in sports medicine. He's soon off to the great city of Boston to join Tufts University, so that'll be exciting for him to be that. You'll get to hear from Shane. Full disclosure, I think I'm a better than average sports medicine doctor, but Dr. Davis is a way better baseball player than I am, so he can tell you about his things with that. I have had a lot of experience, though, with youth throwers, and that's what we're going to talk about today. So when talking about prevention of injury of youth throwers, this is my quote, right? It ain't so much the things we don't know that get us into trouble, it's the things we think we know that just ain't so. That's where we get into trouble. So if some of the things I say today challenge the way you think about this quote and we'll talk about it. We're going to talk about it today. One whole slide of epidemiology, so it'll be quick. Don't fall asleep. Throwing injury facts, right? These are the facts that we know about kids. Then I'm going to turn over to Dr. Davis. He's going to run you through some injury prevention studies, try to make you smart in the literature on this pretty quick. And then we're going to close with 3 big things we want you to remember about injury prevention for kids. And this is they. So our one slide of epidemiology. First thing to remember is that shoulder injuries are more common in older throwers. So we really don't see a lot of shoulder injuries until kids get into high school. Below that, we tend to see mostly elbow. If you look at the elbow, you'll see that's true, right? So 25% of pitchers who are 9 to 12 will have an elbow injury or some sort of elbow pain that will cause them to come see somebody at some point, or they should see somebody at some point. 25%, that's huge. We'll talk about why that is. That goes down a little bit when you get from 1.5 injuries per 1,000 hours in those young throwers, goes less when you get into the high school age, and a lot less elbow injuries in professional sport throwers. Most professional sport throwers are shoulder injuries. Why is this? Why is the elbow? So first of all, remember it's usually not the shoulder in kids. It's usually the elbow. Here's a picture of an adult elbow. Okay, so here's the x-ray. You look at that, it has all the right bones. And Dr. Edwards done a fantastic job talking about that if you see an elbow injury in an adult thrower, it's usually this ulnar collateral ligament that's right here, okay? And that's the one that's kind of throwing, that's causing the problem. But in kids, that's not really the way that it goes, okay? So if we look at a kid's elbow, the first thing we see is there are all these lines and things in here. It looks like the whole bone is broken. These are growth plates, right? These are places where kids are growing and where that bone is actually growing out to get longer actively. And this is what we would call the weak link in the chain, right? So if we look at the ulnar collateral ligament, it actually attaches to a growth plate, and this growth plate is a lot weaker than the ulnar collateral ligament in kids. So as kids have that same force as they're going through those same throwing motions and causing force on their inside of their elbow, the ulnar collateral ligament is not going to tear, right? They're going to yank on the growth plate and break that off instead. And not only are they going to break that off, but you can go further and say kids don't get tendinitis, right? They don't get tendinitis, they don't get muscle strains. If you have a kid who's disobeying what I'm going to call the Edwards rule from now on, right? If they have pain when they're throwing, or if they have pain that's lasting for a day or more after they throw, then they need to come see somebody about that because they've broken the Edwards rules and they likely are having some sort of growth plate injury. And they're not having tendinitis, they're not having muscle strains, they're having that growth plate fracture, okay? So growth plate fractures, as you can imagine, are kind of a big deal. Now, even when it is not usually the shoulder in kids, but if you look at this picture of shoulders in kids, this is a guy who came in to see me not too long ago, right? Here's his right shoulder, his throwing shoulder. Here's his left shoulder, his non-throwing shoulder, okay? Can you see the growth plates here? Look how exploded this one is on his throwing shoulder. And the whole bone underneath is just kind of mottled and looks like it's resorbing and not doing well, not healthy. So this is called little league shoulder. Again, this is a growth plate injury. You're not getting rotator cuff tendinitis. You're not really getting labral tears in kids this young, right? You're going to have a growth plate injury in the shoulder too. So we've got to take good care of these. So growth plate fractures, little leaguer shoulder for sure. So since we know that most of these injuries in kids are going to be some sort of growth plate stress, what do growth plate fractures need? Okay, well, most of all, they need rest from throwing. Okay, and we may shut the kid all the way down for a little bit, but often we get them back pretty quick to being able to swing a bat. We get them back pretty quick to being able to run the bases. It's not all of baseball that's bad on your elbow and your shoulder, but it is that repetitive throwing. So the growth plate fractures need rest from throwing. Stronger muscles don't really help so much, right? Sometimes it's the biggest, strongest kids that have the most elbow pain because they develop the most force, and they throw that ball with more force, and those growth plates are only so strong, and so they're gonna break apart. So just telling your kid to lift weights and get stronger is probably not gonna help so much, right? Good form will help, right? If we can decrease the force across that elbow, that might help us out a little bit, but stronger muscles by themselves will probably not. And here's my last question for you before I leave to Dr. Davis. So what's the last thing a summer pitcher with a sore arm needs? So he's just come through summer ball, right? And it's end of July, and his elbow's sore, right? And he's like, oh, it hurts a little bit to throw. What's the last thing he needs? Fall baseball, right? That kid needs soccer, right? He needs cross country. He needs to go play tight end on the football team. He needs anything else, right, other than throwing something else. So that's one big problem that Dr. Davis is going to talk to you about. But just remember, if you've got a kid with a sore arm, it's a little sore at the end of the season, the last thing he needs is more baseball, so don't do that to him. I'm going to turn it over to Dr. Davis. Like I said, is a way better baseball player than me, and he can tell you about some injury prevention studies and leave you with the 3 things to remember. Yeah, sure.
About throwing injuries and time off from throwing, but you said we can get you back a little bit sooner to hitting.
Yeah.
So that's a question that I think a lot of people are going to have is when's it okay to hit versus when is it okay to, we're going to shut them down for 6 weeks or 3 months from throwing sometimes. Yeah. What about hitting?
So usually when you come see me and we look at you and say, oh, yep, growth plate injury, we're going to help you. We're going to send you to Jared, who you're going to hear from next, right? And we're going to send you to see Jared. He's going to work on your form, and he's going to work on your rotator cuff. He's going to work on your core strength and other things like that. They're going to help that growth plate fracture heal a little bit. And when Jared says you're to the point where you can go back and you can swing a bat, then you can go back. But usually it's about maybe a couple weeks off from swinging a bat. We just got to get that to heal once it stops hurting all the time. So after your elbow has stopped hurting at rest and you've had no pain in that elbow for usually a couple of weeks, then we're going to add an activity like hitting or running the base or something like that. Make sure the pain doesn't come back and keep progressing like that. So it's usually a couple of weeks off. Good question. Any other questions? Then with that, we get Dr. Davis, the great baseball player.
All righty, thank you. So we'll transition now into kind of risk factors of injury and what we think we can do to prevent it. So a recent review article, so kind of an article looking at all the literature that is currently available and trying to kind of put it together and put a good summary together for us. From about 3 years ago at this point, this is looking at risk factors for elbow and shoulder injuries in adolescent baseball players. And you can see from this table here, I want you to focus mostly on the left side. These are the things that have, to this point, really been proven to be risk factors for injury. Age, height, those aren't really modifiable for the most part, right? I mean, that's something we're kind of stuck with. So things that we probably can address, playing for multiple teams, that's a lot of times playing for multiple teams at the same time, playing for multiple teams throughout the year. Pitch velocity, so the harder you throw, the more likely you are to get injured. Arm fatigue, so throwing with fatigue is going to be a big risk factor for injuries. And then pitches per game. I put shoulder there in parentheses because a lot of the data is best on shoulder injuries for that. A few other things that have not been seen to be as convincing of risk factors are kind of highlighted in the middle there. And we'll talk a little bit more about this, but I think one thing that where this breaks down a little bit is, we talk innings pitched, games per year, training days. Those can vary a lot, right? A game, an inning pitch can be a lot different. One inning can be 50 pitches, one inning can be 5 pitches, right? So those can be certainly very variable. So I think pitches per game kind of comes back to being a little bit better look at that. And then we'll talk a little bit about pitch type too. There's been a lot of talk about when should kids throw each type of pitch, and there are guidelines on that, and we'll kind of go towards that on the next slide. But a lot of the data on that's kind of inconclusive or not been shown to really be super convincing to this point in time. And then there's another number of things that we're just really not sure about at this point. So these are kind of common guidelines you'll see a lot on pitch types by age. For the most part, it starts fastball, kind of add and change up, and then a lot of your breaking pitches later on. Like I said, the data on this isn't great to say you should or shouldn't do things at earlier ages. I think the adage is still true, though. You should focus on fastballs, you should focus on control and accuracy, and then you should add on these pitches as time goes. We talked a little bit about velocity, but there was a study that looked at quite a few 256 9 to 12-year-old baseball players, and they found that more pitch velocity and more practice days per week were associated with increased medial, meaning inside elbow pain. That's where that ulnar collateral ligament is. Problems, as well as abnormalities on ultrasound. Just a 6 mile per hour increase on your pitch speed led to a 3 times more likely rate of elbow pain. And then another study does show that preseason ultrasound abnormalities are predictive of injuries within the next year. So it kind of proves to us that those abnormalities that we're seeing on imaging, even if the patient or the kid is not having pain at that point in time, does increase their risk for having pain in the near future. Pitch counts, a good resource is the Pitch Smart. You can look for that online. It's what a lot of the Little League and high school associations will follow. And you can go on the website and they'll have more detailed breakdowns or recommendations by age. But I think the important part, as you're younger, you can throw less. As you get older, you can certainly throw more. And then I think also important, it will show you some of the, the required days of rest or recommended days of rest. So, if you pitch a lot on one day, the amount you can throw on that next day or 2 days later is certainly going to be decreased, right? And it's kind of that acute load, that acute pitching amount, but also kind of chronically, how much are you throwing in a given week or over a season? But I think, an important thing to consider is pitch counts are kind of one part of the picture, right? This study looks at how many pitches are kids throwing, live game pitches compared to kind of total pitches. Because you have pitches in the bullpen, right? You have warm-up pitches, you have, obviously practice pitches and other stuff. And so this is looking, high school athletes, they threw on average 69 pitches per game. But if you look at the average number of pitches they threw on total that day, it was 119. So you're almost doubling the number of pitches that you're throwing in a given day, even though these pitch counts, right, they're more indicative of how many live game pitches are you throwing. So just keep that in mind, right? Just because a kid pitches 50 pitches in a game doesn't mean they threw the ball 50 times that day. They may have thrown the ball 200 times that day, and that does matter. This is a really interesting, let me get the study here as well. Again, kind of talking about why is pitch count not perfect. They looked at a group of little leaguers. They had elbow MRIs before and after their season. And they really closely monitored their pitch counts. So these kids were all pretty compliant with the pitch count. Still, a number of them had elbow pain after 30%. But I think even more importantly, up to almost 50% of them had abnormalities on their MRIs after the year. So that's kind of shown us that even with adherence to these pitch counts, we're still going to have injuries and we're still going to have imaging findings of breakdown. So that's kind of telling us that just this adherence, is maybe not entirely enough. We probably need to consider, how much are they pitching over a year? Are they taking enough breaks? Are they giving themselves time to heal? Just because they're adhering to these pitch counts, if they're throwing all year for every year, they will probably get some tissue breakdown, and that can lead to problems going forward. So what can we somewhat do about these things? There are prevention programs that have been proposed, and they have some decent data to support them. We don't need to get into too nitty-gritty detail. I think our rehab lecturer will get into this a little bit. And these are also things you can look up. But there was a study in Japan recently that looked at some youth baseball players, and they had them do a stretching and strengthening exercise program, and they found pretty good results, up to almost like a 50% decrease in the rate of injuries for these elbow injuries. Similarly, you may have heard of the Throwers 10 program, which is again another preventative program that does some stretching and strengthening. These are good things to include. Like we already kind of heard, throwing is not your warm-up. These programs are your warm-up, and they should be things that are included to kind of help keep you safe. We skip over this guy. So to summarize here and to kind of conclude, 3 important things I want you to remember going forward. The pitch count guidelines are important. Adherence to them is important. We know that more pitch counts are going to matter. We know that they'll lead to more injuries. You got to individualize it a little bit too, right? Everyone's a little bit different. Not everyone is the same size, even if they're the same age. Not everyone's throwing the same amount. Not everyone's throwing just as hard. So just pay attention to that. Pay attention to the kid's, body, how they're feeling, how they're doing. If their performance is dipping, that's important to pay attention to. Really we should be accounting for all throws. If they're a field player, if they're playing catcher as well, these all matter and they count. So it's not just pitches thrown in the game. Ideally, I think we should really have a lot of our kids taking time off throughout the year, playing other sports. Throwing year-round, as we've seen, has not been great for arms. It does lead to more injuries. A lot of the recommendations are 2, 3, 4 months off of pitching per year, playing different sports. And that'll really go a long way towards preventing a lot of these injuries. Preventive programs can be helpful. So those should certainly be something that we're including regularly with our athletes. And then never pitch through fatigue or pain. That's how a lot of these injuries happen. If you catch something early, if you stop early, something that's minor won't turn into something that's really severe and will keep you out a long time. So these kids have a lot of time in their careers. I know everything seems really important at the moment, but jeopardizing the future for a game when a kid's 9 years old or 10 years old is not setting them up for success down the line. And so there's our emails if you guys have any additional questions that come up afterwards. Thank you.
I got a question online, if you wouldn't mind.
Yeah.
This gentleman says, I have a son who had Little League elbow 3 years ago. He still says that he still has some pain tinges in the elbow, mostly when he pitches because he is throwing 100%. My question is, should a healthy pitcher be able to throw without any pain? He is 12.
Yes. A healthy pitcher really should be able to throw without any pain. And we talked, soreness and pain are a little bit different. If you're feeling sore because you threw a lot and you're feeling good the next day and it goes away. But anytime you're throwing through pain, 1, it's probably a sign that something isn't right. And 2, it's probably a sign that things might be getting worse or you're putting yourself at risk for injury. So those are where it's important. 1, to see us as physicians kind of get that looked at, getting evaluated, but also really doing these biomechanical assessments, seeing how the kid's throwing and seeing if there's stuff we can optimize to decrease that.
That's all we got online.
All right, thank you.
Thank you so much. I appreciate you both doing that for us. So a couple of thoughts I had also as we're discussing this is, like was said, I just want to reiterate this, and this is important for a lot of people. If your son throws hard, if your son throws really hard, they are the most at risk for this because they're putting so much force on their shoulder, so much force on their elbow, that you need to really be a pitch count hawk. And if you expect that your coach is going to keep track of that, you're poorly mistaken. You've got to take care of this yourself. A lot of our kids in Utah County play on a Monday night league, and then they play in a city league. And so that is your job as a parent to keep track of those pitch counts. And you can't rely upon both your coaches to do the communicating. So just keep that in mind. And so, for instance, my son is a high velocity thrower. And I don't let him go close to these pitch counts It's been 2 years since he's thrown over 60 pitches in a game. What I'm using is I'm actually looking for fatigue. Are his mechanics dropping down? Is his velocity dropping down? And once I see his velocity drop, time to go, time to pull him out, right? So that's something to think about. So just because the guidelines say you can throw up to 75 pitches, that doesn't mean you should be. Just think about it. And with RMSB, their pitch count rules are innings based, which is their rules. But if you actually look at their website, their guidelines are not innings based. They have guidelines and recommendations on what you should be doing, and they're using the pitch smart guidelines, even though their rules for the game is innings based. So as a coach, I think you should think about that. And we think about it. So if you've got 4 games, you got 2 pool play on Friday, you got 2 pool play on Saturday, and you got championship game on Saturday evening, or 2 pool play Friday, 2 pool play Saturday, and championship bracket on Monday. Think about how you're going to utilize your kids. So for those Friday, Saturday games, instead of having a kid throw 3 innings and throw 50 pitches on Friday and then throw 70 pitches on Saturday, why don't you have the kid throw 70 pitches on Friday and be done for the tournament, right? You've got 4 kids. You're essentially using 5 pitchers for your tournament. So why don't you use them correctly so they pitch one day and then they're done for the tournament, okay? Or if you're going to pitch them if you got a Friday, Saturday, Monday tournament, have your kids pitch, keep their counts low on Friday, keep their counts low on Saturday, and so your kids that keep your counts low on Friday, so the kids that pitch on Friday end up being your pitchers on Monday, and then your Saturday pitchers go long, and then they're done for the tournament. So it just needs to be a rethinking of how we're approaching these tournaments. Instead of having kids throwing 55, 60 pitches on Friday and then 70 pitches on Saturday, that's a recipe for disaster. Okay. So now we're going to talk about some preventive techniques, and I think talk about warm-up and correct warm-up, and we got Jared to kind of help out with this, and we've also got a demonstration here from William's going to participate in the demo here. So we're glad to have Jared. Jared is a doctor of physical therapy, and he specializes in physical therapy and rehabilitation for orthopedics and injury prevention.
Okay. Does this mic stay here?
You can actually clip this on wherever you want, right? If you want to do that, that'll work.
All right.
I'm going to actually raise this up too.
All right, so while we're getting set up here, again, my name is Jared. I'm a physical therapist here at Utah Valley. Grateful to be here, and we've certainly heard some good information thus far. So my goal today was to kind of go over a good warm-up, and we have William to help us here and kind of demonstrate. When we think about throwing and pitching from a biomechanical perspective, normally it's broken down into 5 different phases, and that has kind of been alluded to already. For pitchers, we have our wind-up, and it really is truly a wind-up in that we're getting a lot of trunk rotation, a lot of hip flexion, and things like that to really generate a lot of that power that comes into our throw. The second phase is called the cocking phase, and that's where our arm is abducted and maximally externally rotated in preparation for the next phase, which is acceleration, where all of our power and momentum goes forward into releasing the ball. Once that ball is released, we go into the deceleration phase, as Dr. Edwards kind of talked about, where that posterior cuff and posterior shoulder musculature really has to eccentrically contract and really slow down our movement and momentum. And then finally, we have the follow-through phase, where everything kind of just comes forward and comes to a stop. So the warm-up program we're going to go through today, really, I like it because it takes into account all phases of our throwing motion there. And as a physical therapist, when I get an athlete into the clinic and they're having shoulder, they're having elbow pain, my goal is to take a step back and really look at the body as a whole picture. So we've talked about how much rotation is required from our trunk. I look at hip flexibility. I look at ankle stability and range of motion as well, because all of that really comes into play to be able to throw in a proper way and with proper mechanics. So a lot of these exercises we're going to go over are going to show some of that. So I'm going to have William come up. Really, so this routine that we're going to go through is meant to be done prior to throwing, right? So we want to do a proper warm-up. We really want to get away just from doing static movements, right? Static, sustained stretches. We really want to do more of a dynamic type warm-up that really involves, like I said, all of these phases of throwing. Okay, so we're going to anchor it to the door here.
And this is actually a Theraband. You can buy this online. I'll show you how to make this. I really like this specific version instead of buying the J band, because we can do this at home and do this every single day. We do this every day at home, and this little door anchor here is fantastic for that.
Okay. There we go. Okay. And with all these, safety is definitely first. We want to make sure we're anchored appropriately, right? Okay. And so this first one, are you familiar with the forearm extension? You done that one? Okay. So the first position is we're going to get down into that lunge stance, okay? And then we're going to have our arms above our head. And this one's called forearm extension. So our elbows are going to stay put where they're at. And we're just working a little bit on that forward motion there. Okay. And as you can see with the bands, we're using light resistance, but when we do these, we want to do a lot of repetitions, kind of getting into fatigue towards the end. So usually we'll do about 25 reps of each of these. Okay. All right, then the next two are more kind of dynamic stretches. So the first one, again, we're going to kind of go back into that lunging position. We're going to get our throwing arm up above our head and kind of get it there into some thoracic extension, arms above our head there, kind of stretching out that way. Okay? And let's go ahead and try that one on the other side as well, William. Do both sides here. Good. So this one we call side extension, okay? The next one we have is called diagonal extension, okay? So again, into that lunge position, we're going to take both of the bands onto one side of our body and stretch diagonally that way, yep. And with these two that are more of the stretching type, we want to hold each side at least 30 seconds there. Okay, very good. Okay. Then the next one, we're going to start working a little bit of our anterior musculature, and we're going to do some flies, okay? So our arms are out straight, and we're bringing those bands together into a fly. Good. So with the J bands and a lot of these Therabands, you can keep going there, William, for a second while we don't want to make sure we're overstretching the bands. Really, we only, beyond its lax position, we only want to use about 1 foot to 2 feet there. Good. And so again, we'd be doing about 25 reps of those, okay? Then for the next one, we're just going to reverse it. So we're going to do reverse flies here, starting together.
This is William's favorite one.
Yeah.
He hates the reverse flies.
And then, yeah, so just reversing the motion there. And this one's really going after that posterior cuff, like we've talked about, really involved in that eccentric contraction during the deceleration phase. Okay? So these first 5 I like, and these first 5 are the ones that we use both arms. Okay, so now we're going to get into a little more of our single arm, our throwing arm here. Okay, so I'm going to adjust the anchor here to a little lower, about hip height. Okay. All right, and we're going to start to do some internal and external rotation. Okay, so you're going to use the other hand, and you're going to hold your elbow close to your body, really isolate that rotator cuff. And then this is going to work a little bit of that internal rotation. Really, it's not big movements. We're really targeting the rotator cuff, which is really the dynamic stabilizer of the shoulder while we're throwing. I read one research study that said the rotational velocity in our glenohumeral joints about 7,000 degrees per second when we're throwing, so really needing that good dynamic stability with this. Okay, yep, then we're going to do the opposite, so you're going to face me, and we're going to work external rotation, yep. So this one, you're going to have your other hand pinned against your body. Yep. Good. Doing okay so far, William? Yeah.
You resist as you go back, William. There you go.
There you go. Okay, good there. Okay, we're going to raise the anchor again about shoulder height.
And when you're at the baseball field, you can use a band that has a carabiner on it, and so you just unclipping it on the fence.
Correct. Okay, so then we're going to work internal and external rotation again, just more in the plane of the shoulder here. Okay, so we're going to go here, and here we're working internal rotation. Good. Okay. So one thing I like doing is really working the internal and external rotation motions in several different planes. Very good. Okay, and then you'll face me and we'll do the opposite. Yeah, there you go. Switched hands on me. Okay, so more of the external rotation here with this one. Okay. All right, then the last two we're going to get into more of a throwing motion, okay? So our next one here, we're going to face the anchor, okay? And you're going to hold it with that throwing hand, and this one is a reverse throwing motion, okay? So we're going to go here, and we're going to take that arm kind of through the whole range of motion there, and maybe take a tad step forward so we're not, yep. So we're here and doing kind of that reverse throwing motion all the way around. Good. So try a few of those there, William. Good. Again, doing about 25 reps or so of that one. Okay. And then the last one, we'll face the opposite way, and we'll get into the throwing motion there, the forward throwing. Okay. So arms up to 90 here, externally rotated, and with the band just kind of going through that throwing motion there. Very good. Okay, so that gives you 10 to 11 exercises as part of this dynamic warm-up to really get things warm prior just to getting into your throwing and pitching warm-up there. So it's a routine that I really like, and a lot of players have had good success with it. And I think Dr. Gulbranson's actually going to show us now how to put one together for us.
So I got a question for you, William. When you show up to the baseball field, what do you do? What's the first thing you do? Tell me your routine. Go ahead, start.
So I begin my warm up by dropping my bag and going around for a jog around the field, and then I start to J-bound after I did my jog. So I do all those exercises right there.
All of those?
Well, not all of them.
Sometimes, right? You should do all of them. But
Yeah, and then I do weighted balls. So those are like pilo balls just to get my arm loose, and then I do a shoulder tube, which is just basically a weighted PVC pipe that gets my shoulder pretty loose again. And then, I just start to throw, I guess.
And then you start throwing, right?
Yeah, then I start throwing.
Yeah. So, and the throwing you do, are you throwing hard?
No.
No. How do you start out throwing?
So you're going to start off throwing, you're not going to, dart it in there. You want to start throwing off loose. You want to feel
nice lobs.
You want to feel nice when you're throwing.
Right.
You want to be hurting your arm.
So I think that's a key is if we think about all the things that William does to warm up to pitch, it is literally like 20 minutes at least before he even picks up a ball. So there's a lot of workout that he needs to go through. So that's what I think is really important. So when you get to the field and you drop your bag, you get your ball and get your glove, you're doing it wrong. Okay, you're doing it wrong. And so I'm hoping that this season when I go to the Orem Youth Baseball fields that I see all these kids jogging around the field, they put their J-bands on and they start banding. That's what I'm hoping to see. So let me show you just really quickly how to make this, because you can buy the J-bands online for $45, and that's perfectly reasonable to do. Or you can do what I do here, and this, can I get that clip-on one? Yeah. Thank you. Lights go out, huh? They turn the lights out on us here. You could do what I like to do is actually just to make these. The reason why is that William is notorious for losing things. And we've lost many, many, many bands. And so I'm sick of losing them, so I'm buying these. Now this is about $1 a foot. So I've got 7 feet here, okay, and I've taken 7 feet a length here. And then I just take my scissors and I cut that. Okay, I got 7 feet now. And then what I do is I take a little tiny piece extra of the band here, about so big, maybe, I don't know, that's about 1.5 centimeters. And I cut that. And then I kind of make it even. So I divide it down the middle. And then I take this is a zip tie, and I cut the end off the zip tie. And I put the zip tie through the end like this. And then I slide this little cut piece that I made here down the zip tie like so, and then I roll it over the top. And so now I've got that little piece there that holds it in place. And all I need to do, I don't have a carabiner. Do I have a carabiner here? No carabiners. Anyway, so now I would just take my carabiner, put it through there, clip it on. And then you can buy these handles online from Amazon. They're like $7. And I don't sell these, so I have no disclosures to make today. It's a bad medical joke. Anyway, but essentially what you'll do is you'll take these, the tubing, and you'll slide it through this. Now, what you can also, I don't want to take time to show you how to do that here, but essentially what I did here, you'll do the exact same thing here, so you can get, so that you can then move this thing out of the way when we've got this all slid through. So what we do is come through here once, twice, through there, again, and again. That's all you need to do. Pull it tight, and you're done. That's it. And if you, like I said, if you took this piece here and you put it right here, then you can just slide this in. Now this is where I actually use like a hemostat, or you can use like a some needle nose pliers for like craft needle nose pliers, and grab this. You can slide underneath this little loop here, slide underneath it, grab the tube, pull it through. But you don't have to do that, and that's perfect. That's how that works. So this is essentially a $14 resistance band, right? And you don't even need to buy the handles, right? You can make, instead of making it 7 feet, you can make it probably 9 or 10 feet, and then just make a bowline knot on each one, and that's your handle, okay? And what you can do is you can get the carabiners, or you can buy the wall anchors. Now for the wall anchor, you don't need to use this, you just slide it through there, and that's the wall anchor. And I do recommend that you have it done with a wall anchor at home so that you can do this every day. So which one should you get? This is another good question. I went to a lecture from Intermountain, did one of these lectures about 4 or 5 years ago, and I didn't know which tubing to buy, and so I never ended up buying it, so I just kept buying J-bands. But I'll tell you, so this blue tubing here, this navy tubing, this is the, what does it say it is? It is the extra heavy, the Theraband extra heavy. This is good for about a 12-year-old kid, right? So this is, unless you got a big 12-year-old kid, this is a good size. And then for the older kids, you can go with the super heavy, which is the silver. They don't make any bigger than this, and I find that this is probably right on, once you get a little bit older, like 16, this might not be big enough for you. But what you can do is you can actually just double up on the band, and that can help. So you can double up to give it more resistance. Helps. You can double up to give it more resistance. But that's how you do it. And let me see if there's any questions online before we call it good. Does anybody else have anything they want to talk about before we end today? No. Well, we had good showing online. We didn't have as many people here in the clinic, but that's like, consistent with COVID-19 pandemic, right? Everybody's watching online today. So anyway, thanks for coming out. For those of you that are here and those of you online, we're appreciate you coming out. All right, and you can always comment on the video. I will keep track of that. I can help direct questions to any of the physicians here. If you want to send me a message, that's perfectly fine. All right, fantastic.